Good afternoon. And on behalf of the heart team at Hygeia Hospital, I will present the first case, which is live in a box. You see it's a patient who is elderly, 80 years old, who presented with significant dyspnea over the past few months. And she also had a hospitalization for acute pulmonary edema. Her background, coronary angiography performed in this context revealed moderate coronary disease without any significant targets for intervention, paroxysmal atrial fibrillation, chronic lung disease, rheumatoid arthritis on immunosuppressants for a number of years, osteoporosis, and very importantly, she's a frail lady, a BMI of 14.8. Current medications, you can see them listed. And in terms of her imaging, which we'll review shortly, it showed severe degenerative MR with a prolapse of P2 with two jets, but we'll go in and review the images actually. So this is a biplane imaging from a mid-esophageal view showing that we see a hypermobility of the posterior leaflet especially. We see two jets, one in the lateral side of A2P2 and one smaller jet from more medial position. The jets, even though it's a prolapse of the posterior, they're not eccentric. They seem to be moving centrally into the left atrium. In terms of the 3D appearance, we have on the left side a 3D rendering of the mitral valve. It's a complex valve. We have annular calcification. We have prolapse of the P1 and P2 segments. We have a small indentation between P1 and P2. And we have a bigger indentation between P2 and P3. And we see with color Doppler that we have the two jets. The major jet is on the lateral side of the valve, and a smaller jet that comes from the medial side, and maybe also involving this indentation between P2 and P3. In terms of the modeling of the valve, that sometimes helps us understand what's going on. We can see in red the prolapsing segments. In terms of screening for MTEER, we found the patient to be suitable for MTEER. And in terms of our strategy, we considered going for one device for the major jet in the lateral side of A2P2 in a 12-6 configuration. In terms of devices, we opted for the Pascal ACE, which is a device that we commonly use in patients who have degenerative mitral regurgitation. And here is the video of the procedure. Operators is Dr. Spargias and Dr. Katsianos. And here's the transeptal puncture and entry into the left atrium. I'm going to leave it to sorry, I apologize. He moved it. Okay. Move it ahead a little bit. Is there a pointer there? A pointer? Okay, we'll expedite it a little bit. This is transeptal puncture in the entry of the guide sheath into the left atrium. You see the point of entry, then the release of the septum. That's when the guide sheath is inside the left atrium. This is the Pascal Precision system, the second generation Pascal, obviously. I apologize. Okay. And here's the entry of the Pascal ACE into the left atrium. Once we're in the left atrium, we do the parallel alignment. We assess how parallel the point of entry is over the mitral valve annulus plane. And after that, it's rotating towards the mitral valve, taking care not to touch the walls of the left atrium. So once we're over the so position and trajectory is the main goal of this at this point of the procedure. And once we're fairly well in that respect, we open and assess the clasps, so which one is the lateral, the anterior, which one is the posterior clasp. Once we assess for that, then we can go ahead and assess for perpendicularity. So we want to be 12.6 over the area of interest. With slight counterclockwise rotation to achieve that. Subsequently, here we are doing multiplanar reconstructions where here we're assessing that we're over the major jet of the MR. And next, with MPR, actually, you can guide the whole procedural sequence. Here we have entry into the left ventricle, and subsequently opening the device. And we can assess in the right lower quadrant in the 3D image the clocking of the device without having to change anything else. So we're going to do a little bit of counterclock rotation again. And with that, we can actually go ahead and do the clasping of the leaflets in MPR, which is something that's very practical in a sense. We don't always have the spatial resolution to be clear about it, but in this particular case, it helped, we think. So you can see on the right upper quadrant, it's the grasping view. And it's simultaneous grasping of both leaflets. And if I remember, we did an optimization of the posterior leaflet here. Yeah, we optimized the posterior leaflet. It's a feature that all TEER devices nowadays can do, independent grasping of the leaflets and optimization. So at this point, we want to assess the residual color and where we are. Overall, it looked like a good result to begin with a mean gradient of only 3 millimeters of mercury. However, when looking a bit more carefully, we see that there is this lateral jet just on the right hand of the screen that seems to become very close to our device. And we're wondering whether we can do something more to optimize. So when looking at 3D from above, we can see the color coming from the lateral side of the device, and maybe from the indentation between P1 and P2 that we've mentioned before. So here we bring down the gains and we assess the clocking, and we see maybe the clocking is a little bit, we need to correct it. So with that, with that in mind, we decided to open the device and just clock a little bit, counterclock, to be more 12.6. So once we open the device, we go with 3D afterwards and to assess our clocking. And we did a very minor counterclockwise rotation to be 12.6. And with that, this time in biplane mode, we engage the leaflets. And again, simultaneous clasping. A little bit of shadow on the posterior side, but we're convinced that we had the whole leaflet inside. So here we're reassessing the dropping of the clasps. The remainder of the procedure essentially is to assess leaflet insertion and everything else in the usual manner that we do. We usually reassess, we do a biplane scanning medial and lateral to the device. to see leaflet insertion. Actually, now it's the closing point. Now we close the device. So color-wise, we seem to be very well. We're very happy with the result. We know that we're not going to be able to do anything on the medial jet because it's far away from us. But on the lateral side of things, we seem to be doing very well. So the remainder of the procedure essentially is assessing leaflet insertion, clocking, making sure that we are appropriately clocked on the device, on the valve. And biplane scanning of the valve from one side to the next to see how the leaflets go inside of our device. It's a routine that we always have in all our patients to make sure that we don't, to avoid having SLDA. So once we scan it, we always review the clasping sequences, obviously, because that's the most important thing to have documented is the clasping sequence. Like here, we see how we engage the leaflets and how we drop the clasp, so we have the leaflets all the way into the tip of the device. And here we can measure also how much posterior leaflet is outside. We can do that as well. It was a long posterior leaflet, and we had a good length of it inside our device. And with that, we proceeded to go ahead for release once we measured everything. And this is the release sequence here. You can see it here. It looks very nice if you have fusion imaging on the screen, where you can combine both echo and fluoro at the same time. So release of the device. So what we had essentially is this is a summary of the of our case. Essentially here with the clasping of the leaflets. Sorry, this. Here it goes. Okay. And the clasping here. This is the final result. In 3D, this is our final result in 3D. I mean gradient of 3 with a valve area of 2 square centimeters. Patient did very well. She went home 3 days later, and at 2 months post-op, she's doing clinically well. And with that, I would like to thank you for your attention.
So this is an amazing case. And suppose it's the learning curve like 200 and more, 300 and more. So it's not the first case one should. It's between. It's yellow to red, I suppose, right?
I would say a yellow case overall. Yeah. It wasn't very difficult to grasp the leaflets, but they have their details. Essentially, we have to be very nicely perpendicular to the coaptation zone. It's very important for us.
And I suppose you use Pascal ACE in all these cases. So would you consider a mitral clip XTW in another situation, or you think you wouldn't have this result with an XTW?
I think, based on the 2D study, the CLASP 2D study, both the devices are equivalent, essentially. We could have easily used a mitral, an XTW device. The leaflets were long, and I think we would have gotten a similar result.
But it's less traumatic, right? So maybe you get away with some damage to the leaflet because it's more benign.
Yes, I mean the major benefit of Pascal is that it's from nitinol. It's more of a passive device. It's not applying excessive forces on the leaflets, so it's less likely to cause leaflet injury. Again, for these prolapsing valves with long leaflets, we want a tight grasping of the leaflets. So both devices will do the same job, I think, very well.
Congratulations, Dr. Chrysoheris. I think it was a very important lesson for all of us, this case, because even though it was not a technically very, very, very difficult case, I think that the lesson that we need to learn is that the attention to detail. The first result, after you first showed us the result, it was not that bad. So someone could have stopped the procedure at that time. However, you were persistent and you decided to release the leaflets again with, you know, like having a more difficult life. And the result was really excellent. Not that the first result was not, but then the persistence in those cases, I think it's a very important thing for the good result for the patient, first of all. Thank you.
Absolutely, you have to pay attention to the details because even though one case may be easier than other cases, you have to follow your standard sort of way of doing things because you don't want to miss something and you don't want to have SLDA or other problems in the future. So absolutely, I think we could have stopped. One could have stopped early, but absolutely you have to point to and to try to have your best result as possible with your initial device.
So thank you, Mike.